Excellent presentation. We really have enjoyed our guest speakers so far. We feel that they have given us a different insight into some materials that they're studying more intensely. And we do want to thank Dr. Griffin for taking time out of her day. We are going to continue. Some of us are still under a tornado warning, so once again, I do want to let you know that we may end up losing power, or if you see me quickly hopping off the screen, there's a reason why, but we are in a really safe location here. So we are going to go ahead and do our polling questions. These are the last two that we will have today. We do want to remind you to want to go to pollev.com/VCU Health CME or text VCU Health CME to 22333 to join, and then you'll select A, B, C, or D as your answer. So our first question is, which answer best describes how a provider can treat both patients while maintaining their trust and confidentiality? I cannot see those answers to read them, so hopefully everybody can read them okay. Thank you. The law allows patients' information to be shared with other patients without a release of information. Patients expect that their information will be shared because the provider knows both of them and does not need their permission. Express understanding of their friendship and how it is important to protect everyone confidentially, but information cannot be shared without written permission, or none of the above. So I see that a majority of us do have that answer correctly. We are not permitted to share information with mutual friends or family members without a release of information. And I do know sometimes that is very troubling for folks, but it is something we do need to be conscientious of, and we're going to talk about that a little bit more in our talk here today. Our second question is, pardon me? One question? Okay. So what I'd like to do is move into our talk about confidentiality. And one of the things that I think all of us have been exposed to in some time of our life is that someone has betrayed our confidence. Think about how you feel if that happens, whether it's a family member, a spouse, a friend, but especially if it's been a clinician or provider that has been taking care of you. Now, what would you think about that person, and how would you want to handle how careless maybe they were in taking valuable information that you had provided to them and maybe displayed it to other people without, your permission? What clients share or patients share with providers is very personal. And I do know that providers will at times say to a patient, "Do you mind if I share this information with my medical home team? Or I feel that this is something really important and I'm going to have to talk this over with my medical home team," or whomever, because it's very important that we get this information out. We need to make sure that patients are aware of when we are going to be sharing something that they might be telling us in confidence. And I think that sometimes we do lose focus of that. I will tell you that just in a generality, point of view, when I'm not talking about patients, but when I'm just talking about something to somebody, sometimes I'll catch myself and be like, boy, maybe I shouldn't have said that. And sometimes I need to think a little bit more clearly before I say something. Although it's not betraying somebody's direct confidence or confidence in you, it might be something that you might not have been willing to share with them without that person knowing that you had provided that information to them. So confidentiality is really important in any professional relationship. And although we are focusing on relationships between patients and, in this case, maybe our community health worker team or our clinical provider team, we do all expect our privacy to be protected when meeting with professionals. And, sometimes I just think that we're human. And we have to be aware that, there are times when maybe we didn't do something the correct way, but then we need to take some ownership of that. But in all of our training and everything that comes to our forefront, when we are hired, when we are put through different, training sessions, we always need to be cognitively aware of that privacy and that confidential information for somebody, and wondering how that would be if somebody did that to you. So, we talked about confidentiality a little bit, which is the responsibility for protecting private matters from unauthorized disclosure. But there's also two other definitions that we want to talk about here today. The other one is privacy. I mentioned that just a few minutes ago. That's the right for someone to be left alone. We may not always agree with that. Think about times when you have been maybe in a situation where you just didn't want to talk to somebody, and someone's coming up to you and they're saying, hey, what's wrong? Or, why didn't you answer the phone? I was calling to see if you were feeling okay. And you kind of are like saying, hey, I got this. I want to be left alone, and I'm going to let you know when I'm willing to talk to you. As especially adults, 18 years of age and over, we need to respect that privacy, because that person is making an informed decision that they feel is beneficial to themselves. The third definition I want to talk about is security, and that means to control access and protect information from accidental or intentional disclosure. Again, I know it's something that we're all conscientious of when we're going to work every day and we are meeting with families and patients, and we want to make sure that they know that we got them, that we're not going to betray their confidence. And we need to make sure that we do really focus on this on a day-to-day basis. And I know sometimes we get wrapped up, people become frustrated, we become frustrating. And so we do want to make sure that we're maintaining these three important definitions as we're continuing to go through our day-to-day activities as healthcare providers. So the one thing I do want to talk about is the different types of laws that we need to be aware of in our practice. Most of these are terminologies that if you are actual healthcare providers or social workers or case managers or advocates, you probably have heard these many times. But I do think we need to take a few minutes just to go over them and make sure that we understand exactly what we're talking about here. So of course, our first one is the Health Insurance Portability and Accountable Act of 1996, better known as HIPAA. So HIPAA is really significant at any time when you're dealing in healthcare. Every time you go to a medical appointment, I'm sure someone's asking you to either electronically sign now or, make sure that you're aware that, your information cannot be shared with somebody. And, we do go ahead and make sure that those things are taken care of. But I'm going to tell you a little pet peeve I have about this. We're really conscientious about people, signing these documents, not saying somebody's name when, we're signing them up for an appointment or, when we're in a hallway, we don't talk about somebody. But I always find it interesting when a patient's name is called out in the lobby and they're sitting there. I think that really is something we need to be more conscientious about. Maybe there needs to be another way. I know sometimes it's the first name, Shirley J. or whatever, and that's fine. But if we're being really conscientious about protecting the privacy of patients, I do sometimes find it ironic that we're using full names as we're calling people back for their appointments. And, I know that there's maybe some ways that we can't get, through that, and there's maybe some things that we can't do to change that. But I always find it very interesting how many times we're, constantly taking these trainings at work and, make sure you're protecting people's privacy. And then as soon as you go to a medical appointment, someone's shouting someone's name out. So what I thought I would do at this time, before we go into the other disclosures that I think are important to go over as far as laws, is I wanted to give you a practice situation, and we're going to do like a 10-minute breakout session where after we go over this story, I want you to maybe go into those rooms like we did before. You could change, your new rooms. You don't have to go in the same number you went to this morning. And then we're going to open up the mics, and I'm going to try to encourage a couple people to talk about what you all spoke about in that meeting. And I feel that this is very important because this talks about that friendship issue that we were speaking about. Like, can you tell somebody about a mutual patient that they know as a friend and that you're caring for as a provider, and how would you handle that? So let's take this scenario. At your second visit with Anna, you discover that Anna and another one of your clients, Tiffany, are friends. And that happens a lot in the sickle cell community. We find that many people do exchange phone numbers and they know each other through support groups and all those things. So when you arrive for your next visit, Anna asks you some questions about your work with Tiffany. What is your legal obligation to this situation? Okay, let's go into our breakout rooms 1 through 9. Pick one that you want to go to, and we're going to give you about 10 minutes, and we're going to come back. And I like it if some people would be gracious enough to open up their mics for about 5 minutes or so, and let's talk about that.
But we definitely came up with that the information definitely cannot be shared. Understanding that, you can do anybody's PHI, use anybody's PHI, share anybody's PHI, without their consent, And also when you can, we talked about, that when you can, you also have to, if they do give you permission, you still want to use only the necessary information to perform your duty. You only want to, just also share only the minimum necessary information, all of those great things. But I also told them that I felt that there was a good chance also for the doctor, because I think they said that it was someone who knew, it was a friend, she was a friend of the patient, and she came in and asked the doctor. That's what we thought the question was. Is that correct?
No, they were actually both patients, and the one patient came in asking information about the other patient.
Right. Okay.
That's okay. It's the same situation.
Yeah. And so we also thought that may also be a teaching lesson. Also, not downgrading anyone or saying you should, but maybe just explaining to them, also, per HIPAA we cannot, also kind of like giving a person a little education, but doing it in a real soft and kind way too. So that was some of our thoughts. Thank you.
Well, thank you. Hope you guys are staying warm in Michigan. How about one more person? Do we have anyone else who's willing to chime in? We love hearing from you. I see some of those faces up there, and I see a couple people still have their pet pictures up. So is there someone else that would like to chime in and give us an answer, or should we just move on?
Okay, so it's Veronica again.
Hey, Veronica.
Hey, I had asked Ben to do, we were in group 1, but he may be busy. And but anyway, I
couldn't unmute.
Oh, okay, Ben, I didn't know you were on.
Go ahead.
Okay, I'm actually a nurse case manager, chronic disease here in Montgomery, Alabama at Baptist Health. And ironically, I don't deal with sickle cell. I'm a congestive heart failure guru. However, because our sickle cell program closed, when we have frequent flyers, which we call MVPs, they call my boss and she puts them in my lap. And I'm like, you're trying to kill me. But anyway, our thing was, and Ben and I both agreed, when patients do that, and they tend to do that here in Alabama because everybody knows everybody, who are you talking about? I don't know what you're talking about. Are you sure they come here? I don't know. And then I explained to them later that, when we're by ourselves, you wouldn't want me to share your information with anybody. So try to remember to respect the person that you know, whether it's a friend or acquaintance or whatever. Try to respect their privacy as well. And that usually goes over pretty well so far. So that's how we deal with it. We know and don't know.
Well, and I think you're all saying the same thing. So if you look at the results, you've already spoken about this, that we have a professional obligation to protect Tiffany's rights so that she will continue to come see you for care. And also the law, and also depending on your employer and what their responsibilities are, depends on the requirements of how you're going to handle that relationship between yourself and Tiffany. And of course, you want to express when it's appropriate that you understand that there's friendship and that maybe there is some information that this patient is aware of, and I know you're maybe trying to help this person, but we have to protect not only Anna's privacy, but also your privacy to Anna if you would be if she knew you were a patient here too and she was coming in and asking the same questions. All right, let me take these off again. Come back. Okay, we already talked a little bit about HIPAA, so I'm going to pass through this slide pretty quickly here. And I want to just talk about some of the other acronyms that I heard some of you mention when you were responding back to us, which of course is PHI. We're going to go over that a little bit here. And we're going to talk about privacy practices, where you have clear written explanations of how a facility may use a patient's protected health information, because sometimes that is important and we need to make sure a patient understands that. And the minimum necessary rule, where any disclosure must be limited to the information necessary to carry out the purpose of the disclosure. So first, let's talk about PHI. All this information listed on this slide is your private health information that we cannot give to anyone else without your permission. So I'm going to use research as a really good example. If you are being recruited into a study, your private health information is part of that that information that research assistant is going to be coming in and going over with you as part of your consenting process. However, in that consent, there may be certain checkboxes where they may have to say, we have to do A, B, and C, and this information is going to be either de-identified or identified or whatever the circumstances are, and you're going to check that box and agree to that information being submitted to whatever the researcher is telling you where it has to go. Without your permission, we should not be disclosing any of this private health information. And I think most of us in the field are well aware of that, and I'm hoping that patient and patient advocates know that this is something that we have to go over on a regular basis, but it is something that we want you to understand when those challenges and changes do occur, and that you have to provide information to that. So patients' rights regarding health information is what I just got done talking about with the PHI and how it's protected, but we have to sometimes review records and request changes for certain reasons, and we want patients to be aware of that. We also must be informed as who will see those records and may restrict how that information is used. So once again, let's use the research coordinator. That is somebody who may be allowed to view certain records for an upcoming study, but they are restricted on how they can use that information. They must receive a clear explanation of how a facility uses their information, meaning you, the patient. So as part of that HIPAA or part of that consent that you're signing, there should be some kind of dialogue in there that says something about how some of this information may be being used on your behalf. And looking at the minimum necessary rule, it allows disclosures of relevant information, and we want to make sure that you understand, again, how this might be related to routine treatment, payment and administrative functions, and non-routine disclosures such as reportable diseases, vital statistics, suspicion of abuse or neglect, which we're going to talk about in a moment, and other legal considerations. So before we get into some of those other terminologies, I just also wanted to go over really quick about how we have to take care of people who have substance abuse treatment and we protect their privacy. This is something that is really critical, just like mental health is, because of course there's stigma related to people who have substance abuse. We do know that some of our patients do have alcohol mismanagement or opioid mismanagement and may have to go in for substance abuse treatment. And this is called the 42 CFR Part 2 Act. And we want to make sure that anyone who's going in for treatment understands how your information is going to be protected. This regulation applies to specialized alcohol or drug abuse programs paid for with federal funding, programs that provide treatment, diagnosis, or referral for treatment. However, anyone who receives information about clients in these programs is subject to the rule and may not disclose this information except as permitted by this rule. In addition, substance abuse treatment programs subject to 42 CFR Part 2 must comply with HIPAA requirements. Now that says a lot, but it's basically saying what I just got done reporting to you. When federal funds are involved, there is certain guidelines that still have to be overseen by whatever facility is providing that treatment. And you as a patient need to understand how your rights are going to be protected if you're seeking substance abuse treatment. And that's pretty much what this says here as well. So there are times when these rules don't apply. I think Rachel might have touched on this a little bit yesterday, or maybe Alicia. But anytime that you are seeing a professional and they become aware that there is suspected child abuse or neglect, whether they suspect there's domestic violence, whether they suspect that there's adult abuse in some capacity, we are mandated reporters by the law. And we would have to say to you, you are disclosing information to me, and by law, I have to report this to the appropriate authorities. That supersedes any release of information that you have already signed. We also have to do the same thing if we believe that an individual is suicidal or homicidal. We have to make sure we take their safety or the safety of others into our care and make sure that we are providing the safety net that we can to make sure that they are going to be well. That consent that you sign, this supersedes that particular consent. If you have committed a crime or you are threatening somebody in the program, once again, we will go to law enforcement, and we will need to do what we have to protect you or to other people. So those are allowable disclosures that everyone should be told in some capacity by your professional providers or be made aware of that. Not on every visit, I don't think that that's necessary, but I do think that there are times when information is being disclosed that you need to make sure that patient understands that you are a mandated reporter. That goes for social workers, that probably applies to patient advocates. I'm not really sure if that law is actually in place, but if you're working with somebody on a professional level, I don't know, Joan, do you know? A patient advocate? They do follow the same mandated reporter guidelines. So we do need to make sure, to an extent, that you're making that patient or that family member aware of what you will be doing to make sure that you're protecting the information that they're providing to you so somebody does not get hurt. This particular rule applies to children under the age of 18, called the Family Education Rights and Privacy Act. And it's a federal law that protects the privacy of student education records and personally identified information from education records. This information includes a student's name, family members' names, addresses of the student or the family, social security numbers or other unique identifiers, birth date and place, and mother's maiden name. This is a really important act that has been instituted by the U.S. Department of Education, and this is virtually taken care of by all public schools. Private schools do have different requirements. So this FERPA Act, if you are sending your child with a disability to a private school, they are not required by law to follow this particular act. So I'm sure that those of you who have young children, if you put them in private education for whatever reason, I'm sure you're their strongest advocate and you try to get those things in place for them, but just be made aware, and I'm sure you have been, that private schools do not have to follow this particular act. So parents' rights. I am not in the pediatric setting. This is not something that I routinely go over, so it is not I'm familiar with it, but it's not something that I do or most of my staff do on a day-to-day basis. But we do have rights for parents and eligible students regarding their education. Again, talking about the FERPA Act, we want to make sure that you are given annual notification of your rights under the FERPA Act if your child is in public education. You need to inspect and review your child's education records and to seek to make sure that those records are being protected at all times. Some control over the disclosures of this information from educational records need to be relayed to you so you do understand, again, where those particular disclosures may no longer apply. Again, if they suspect child abuse, neglect, domestic violence, these same things all apply to mandated reporters in education setting. There is an annual consent form that is signed, dated, and includes the purpose of disclosures, which you should be provided every year that your child is in public school, from kindergarten through the 12th grade. So I know we continue to hash and talk about confidentiality here, and it's really important for all people that are working with any population, any student, any adult, that you understand the importance of confidentiality. It's really important for relationship building. We've talked a lot over the course of the last 3 days about trust. One of the most greatest things that could ever happen is that you lose your trust in someone. So we want to make sure, again, I know it sounds like we're repeating ourselves, but we want to make sure that you understand that your trust in us is extremely important as the providers who are giving care to you or your family member. It is also your right, and you're protected by law to make sure that that trust is not being broken. And you have an ethical responsibility to protect. We have an ethical responsibility to protect your client or your child's protected information. So let's do another scenario. We're not going to do a breakout session, but I just kind of want to use this analysis because I think it's really important. Imagine for a moment that you were handed a $1,000 bill out of the blue. First of all, I'd be jumping up and down. I thought that would be very exciting. But you didn't earn the money. It was given to you as a gift. What would you do with that money? You would protect it and put it in a safe place. You could think about your client's private information as that $1,000 bill. To your client, the information that they are providing to you is valuable, just like that $1,000 bill is. They have given you that gift of their trust, and you have broken it if you share their personal information that they have provided to you. That trust usually cannot be repaired. Once somebody important to you breaks that trust barrier, it takes a very long time, if ever, for that ever to be reestablished. Again, that's both on a personal and professional level. So, again, think about each patient as a $1,000 bill, and that you're going to handle them with care and respect, just like you would if somebody handed that bill to you. Now, I know that sometimes I'm guilty of this, and I'm going to admit it. I'm sure my staff that's sitting on here will definitely agree with you, that sometimes I don't think before I speak. I have a tendency sometimes to speak with my hands and sometimes just blurt things out, but you know what? I really don't intend to hurt anybody. I'm just kind of giving my opinion out there, and sometimes I don't think about the consequences before I do it. Have all of you done that? I bet you every single person sitting on this Zoom and sitting in this room has done the same thing. We don't intentionally mean to harm people, but sometimes we just don't think about things before it comes out of our mouth. So when that happens, we also have to be the greater person and accept responsibility for that. Be aware that there are all kinds of confidential information that you possess and that you are responsible for protecting. Double check your contact information before using it. You want to make sure that if you're calling somebody and that person is not the person answering that phone, which I know nowadays is a little bit different with cell phones, that you are not providing identifying information as to who you are, saying, hey, I'm Shirley Johnson, I'm calling from the VCU sickle cell program. Is Sue there? And Sue's not the person answering the phone. Safeguard any client information that you carry with you, and try to maintain confidentiality 24 hours a day, 7 days a week, at work, at home, and in the community. I want to share an example with you of sometimes how, and I'm sure this has happened to almost everybody in this room. I was working in transition years ago. There was a wonderful young lady that was part of our program. She would come to all of our transition events. Both her and her mother were very engaged. And I felt over the time that we were doing this program, we had really built a nice relationship. So I was out at the mall, it was Christmas shopping, and she comes up to me and she goes, hey, Miss Shirley, how are you? Well, standing right next to me is my husband. And I've told my husband on numerous occasions, I've been married for a while, if I don't introduce you to somebody, there's a reason why. One, I might not remember their name, sometimes that happens. And two, it could be somebody that I have worked with or am working with, and I cannot betray their trust. So I turn around and I'm talking to her, and she goes, you know who I am? Of course, I knew exactly who she was. And I said, yes, it's nice to see you again. And how are you? And are you here shopping for the holidays and all that? And she's like, oh, yes, I am. And she goes, who's this guy? And I said, oh, this is my husband. And he's just kind of standing there. And she goes, hi, I am so-and-so. Well, she said, I work with Miss Shirley. She has really helped me in getting ready to graduate and move on to the adult sickle cell program. I have sickle cell disease. She provided all the information to him on how our relationship had been developed, and I felt very comfortable then at that point in time continuing to speak with her, and even said to her, is it okay if I talk with you about this since he's standing right here? And she provided her consent. Sometimes that's kind of a tricky situation. I know that sometimes, I think it was Veronica, she was saying, in the area she lives in, everybody knows everybody. That's even more challenging. In Richmond, it's a very large area, very few times you run into people. I think probably in the 13 years I've been doing that, it's happened to me twice, one of them being the scenario that I just provided to you. So just be awarely aware, and if you're with other people, spouses, friends, or whatever, if you're a therapist, if you're a physician or whatever, obviously these discussions probably have happened in your adult life with your spouse or someone. You just always need to let them know. There may be reasons sometimes why I can't say something in front of you without, somebody else identifying who they are. So I just wanted to go ahead and review the 4 reasons for maintaining confidentiality, and I'm going to kind of go over these pretty quickly because I know it's been a really long day and it kind of sounds redundant. But maintaining confidentiality will establish a trusting, positive relationship with your patient. Confidentiality is the client's right and is protected by law. And here it was where we were talking about patient navigators. You have an ethical responsibility to keep the client's information confidential, and most programs are housed within agencies that have policies and procedures related to confidentiality. All of us at VCU have something sitting in our queue right now that's due by the end of today related to this particular topic. So it's something that we're constantly having to go through, virtual trainings over, and to making sure that we're abiding by the rules that have been set up by our institution. Something that I think is really important, especially in relationship to some roles that we all have, but I think it could really be used for anybody, is maybe developing a confidentiality script that includes like several of these elements. When working with the patient, you want to make sure they understand what confidentiality is. Explain to the patient that there are laws that protect that confidentiality of their information. Explain that that information is protected at all times, that the client's rights are also protected by law. Give reasons why you might need to share information. Go through forms step by step and give client opportunities to ask questions, and make sure when that person is signing that form that they know what they are doing. I would suggest, and we have done this in the past, you actually have a little printout with some of these same information on it that you could hand to patients and go over it with them. Remember, don't always assume that patients have the ability to read what you put in front of them. There's a huge literacy issue and a huge gap many times for a lot of our patients due to the fact that they've had some cognitive limitations as a result of their disease. Don't always ask sometimes if somebody, oh, here, I'm going to give this to you. Is it, do you understand what it says? Because they're going to nod to you. Just go over it very gently and do it with everybody so that you're not kind of making one person feel different than the other. Also, I would suggest that you develop a checklist of things that you must consider before sharing a client's personal information with anyone. This is more for you. Does your client know or your patient know what his or her rights are? What laws apply to the situation that you're about to go ahead and relay to somebody? Do you have valid consent to share that information? And should you talk with your supervisor before sharing this information? Yes, yes, and yes. You always, I don't care who you are in the food chain, you should always go and get someone else's opinion before you start making reports to somebody else that might violate this information. How can you safeguard the confidential information you possess? And if you must disclose the information, what is the most secure method to establish the task? I think if you take these particular points, I believe there's 5 of them, and you look at this as part of your, I'm going to say in quotes, your Bible, this is a way for you to know that you're moving in the right direction if you feel that you have to break the confidence of someone that you're working with. Now, this is our last slide for the day, and it's about COVID, which I know we're all pretty much tired of hearing about. But COVID is not gone, and if COVID goes away, there could be a next pandemic, and we need to be prepared for that. While we've all been going through, COVID over the last 2 years, there was different forms of how we were kind of relaying or talking with patients. Zoom, which is a great platform, is not HIPAA protected. But many times, we've had to hold appointments with patients over Zoom. Especially early on in the pandemic when nobody was coming into the clinics. We also had done FaceTime. But the most protected way of actually securing your privacy with a patient is through Doximity, which is an app or a software that is provided usually to providers that has that HIPAA component to it. And of course, there's the phone. Even though there's no visual interaction, you could still speak with a patient, and you're not really violating anything at that point, because usually, again, with cell phones now, it's the patient and the provider. Just making sure as the provider or the person that's talking to the patient, you're in a secure area so nobody can really hear what you're talking about. We really don't know what the future holds right now when it comes to COVID or our next pandemic or our next crisis. But we do want to make sure that we're still protecting patients as much as we're able to. And I think that we have to be really cognizant about how we've been able to adapt over the last 2 years, the challenges we faced in the beginning, and I'm sure that we all fell on our faces a couple times, and then how we're going to move forward as things continue to evolve. Many of us are going to continue a hybrid approach for work. Some people still have to go into the office every day. Some people might never go back into the office again. If you're any of those folks, how are you going to continue to do what you need to do to make sure that you're protecting patient rights? So I see that we have a couple questions here, and we're going to move through these fairly quickly so we could try to get you guys out of here by 3:30. But what is the health literacy level of understanding when the patient okays because they trust the interviewer and really does not understand the patient privacy statements? That's an excellent question, and it kind of goes back to what I said. I think we should try to treat all people equally. And don't assume because somebody looks a certain way or acts a certain way that they have better reading levels than other people. So again, my suggestions are that, sometimes when you're looking at long releases of information, there's a lot of, verbiage in there that is really just, lawyers sitting at a desk and trying to figure out what to say. I always say get a couple bullet points of the really important things that you want your patient to understand and go over those with them. If they want to choose to read that release of information, or we think they're reading that release of information, that's fine, but always go over those really important things. Okay, Joe, let me say to you, these are some things I want to make sure we're pulling out of here before you sign that consent. Blah, 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 blah. I think that's really important. Any other questions or comments? What is the health literacy level of understanding when the patient okays? I just went over that one. Is this because private schools likely do not receive federal education funds? I think so. I honestly don't know the answer to that, but I would think it's because they are not federally funded, so they don't have to fall under those same guidelines. Oh, regarding the FERPA Act, yes, that's correct. How do staff comments, frequent flyer, hard stick fit into privacy laws, and how do we address these sorts of comments in light of privacy rights, PHI, MNR, and continuity of care? I was wondering who was going to ask that question when somebody mentioned that just recently. I know that it is very hurtful to hear providers talk in those kind of words. It's a language that we use, and it's not appropriate. I think that we have to always be sensitive to the fact that we don't know who is listening, and to making sure that we're doing things in a way that is we would want to be treated. So I do know we use terminologies like frequent flyer, most valuable patient, sofa surfers, all those kind of connotations that are really hurtful to patients. And I think we're getting better at that. I know in our practice, I don't feel that we really use those like we probably did several years ago. We've gotten better about understanding how painful that is, and that's because we've heard from other patients telling us that. I think it might have been in our first SCCAPE conference, as a matter of fact, when we were actually sitting in that big room, and I know one of those ladies that's sitting here looking at me with her picture right now could probably attest to that, but it was a dialogue that came up about using those terminologies, and I really had to stop and think about that and say, yeah, that's really true. I wouldn't want somebody to describe me as blank, 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 blank. So I think it's just about, gently reminding people in our profession of how things could be hurtful. It's the same dialogue about talking about race with providers, stigma that Dr. Griffin and Dr. Smith were speaking about. It's all about education, and I don't really believe most times that people intend to be hurtful. I think it's important to realize that sometimes as providers of sickle cell patients, we are frustrated. And that's not just about probably with sickle cell patients, but with patients in general. But as long as somebody's calling us out in a very professional, respectful way, we have to train them to be better. That's what all of our jobs are here to do today. We're giving you information. Many of you might have known about all of this information that I just went over. But make sure that if somebody's stepping out of bounds and it's going to be hurtful to someone else, that you're gracefully telling them something in a way. Don't call them out in front of a crowd. Don't call them out in front of your team. Gently take them aside and make sure that you have a discussion that is professional and that they understand where you're coming from. I'm going to thank you. I'm going to turn the platform back over to Joan, and we will see you tomorrow.
Thank you, Shirley. And as she just said, we probably have all heard this somewhere along the way. I know we have, but it's good that she brought up some very good, insightful thoughts that we all should rethink and reconsider and acknowledge. All right, so we are going to wrap up for the day. That's all the time we're going to take for today, and we appreciate all of your participation and being with us. We're grateful for your insights also, because we've had some good discussion today. I also have a couple of announcements. Obviously, I want to remind you about claiming your continuing education credits. If you've not already done so, please follow the directions on the screen to record your attendance by text like you've done the last couple of days. We are so glad that you've joined us for these 3 days. We hope that everybody will come back first thing in the morning. We will start again at 8:15 for our day 4 session, and we've got some packed information ready to rock and roll. We've got a couple of speakers that you've not heard from, so I think we're going to have a good day. And be well, have a nice evening. Hopefully we can all stay safe from tornadoes and snowstorms and whatever else is going on out there. So thanks for a wonderful day. Have a good evening, and we'll see you in the morning.